So good afternoon. I'd like to welcome you to the first webinar of this year's ESTS webinar series. And it's a pleasure to have Xavier Benoit-Journo here today to talk about esophageal cancer, update on surgical treatment in the multidisciplinary setting. Esophageal work is, as we know, something that is organized very different in thoracic surgical departments. And he's head of the Department of Thoracic Surgery, Diseases of the Esophagus and Lung Transplantation at Marseille University Hospital. And there's a huge workload on esophageal cancer cases. And so I'm looking forward to receive his insights and an update on current treatment strategies. Xavier.
Good afternoon, everybody. Thank you very much, Clemens, for your kind invitations. I will just share my screen. Is it okay? Is it in full screen mode? Okay.
Yes, perfectly fine.
Thank you, everybody. Thank you, Clemens, for your kind invitation. I would like to thank the European Society of Thoracic Surgery for the kind and continuous support in supporting and teaching esophageal cancer surgery. I personally think that esophageal cancer surgery is completely part of our specialty. So the topic of this presentation will be to discuss and to give you update on surgical treatment in the multidisciplinary setting. This is my disclosure. As you know perfectly, we now assist to a very huge change in epidemiology of esophageal cancer. We have a very huge decrease of squamous cell carcinoma. And since the last decade, we assist to explosion of incidence of adenocarcinoma. From the SEER database, there is a 7-fold increase risk of developing esophageal adenocarcinoma compared to other solid organs. The second point I would like to emphasize is that the vast majority of patients are delayed diagnosis, and that can explain the poor prognosis of the disease. Only 21% of patients have early stage at the moment of the diagnosis. Vast majority, 42%, present locally advanced tumor, and 37% remain metastatic. That explains why 70% of patients proposed for surgery are receiving a neoadjuvant treatment or adjuvant treatment. In this setting, we perfectly understand why the MDT, the multidisciplinary tumor board, is essential. And the French regulation system now requires to have an official decision, presence of a radiation therapist, surgeon, oncologist, pathologist, radiologist, and interventional endoscopist. This very crucial role of the MDT is explain why there is a so high rate of concordance between the MDT decision and the applied treatment. But the MDT has to be regularly asked to reassess the decision because of intercurrent disease, comorbidities, and poor nutritional status. That explain why 28% of patients undergoing neoadjuvant chemoradiotherapy finally did not receive plain esophagectomy. So in this lecture, we will discuss update in patient selection for surgery, in surgical principles and main indications, what are the place of neoadjuvant treatments, what are the place of adjuvant treatments, and few words on the place of salvage esophagectomy. So first of all, patient selection and indications. Nowadays, we use mostly the ESMO guidelines, the European Society of Medical Oncology, that update their guideline next year, 2022. I just remind you the main indications. For limited disease, the recommended indication is upfront surgery. For locally advanced tumor, you have to take care about the histological subtype. For adenocarcinoma, you can choose between perioperative chemo followed by resection, or choose between neoadjuvant chemoradiotherapy followed by resection. For squamous cell carcinoma, you have the possibility to use neoadjuvant chemoradiotherapy or definitive chemoradiotherapy, and after follow-up, propose salvage resection in case of relapse tumor. The preoperative workup is very strict. You must have endoscopy, endoscopic ultrasonography, body CT scan, TEP CT, and you can propose a laparoscopy surgery in case of adenocarcinoma to rule out carcinomatosis, and you can go for tracheobronchial endoscopy if you suspect clinical or endoscopically tracheoesophageal fistula. Non-resectable tumor is considered if you have a clinically or endoscopically sign of tracheoesophageal fistula or a direct left atrial paralysis. And you can consider the tumor as non-resectable if you have on CT scan or on laparoscopy direct invasion of aorta, vertebral invasion, distant metastases, bulky lymph nodes tumor, or carcinomatosis. One of the most progress we have is probably in the patient selection, the possibility to have a risk prediction model of the 90-day mortality. And this is very crucial for to test the eligibility of surgery, for promotion of care-related quality improvement, but also to assist patients in giving comprehensive and informed consent, and to assist practitioners in adding granularity in decision-making process and patient selection. So I have the privilege to present you what we published in JAMA Surgery 2 years ago. This is the result of ESG score, International Isodata Study Group, summarizing more 8,000 patients among 36 centers in the world, and we are able to make a prediction model based on 7 variables, 7 preoperative variables: age, sex, performance status, VMI, comorbidities, neoadjuvant treatment, and volume centers. And according to this score, you are a predicted 90-day mortality. For example, if you have a score of 5, you have a predictive mortality of less 1%. For a score of 0, you have 3% of mortality. For -10, you have a predicted mortality of 43%. And based on this score, you are able to have a good prediction model and to give informed consent for the patients. Surgical principles are well known and should be absolutely respected. You must propose a complexness of resection with a R0 en bloc oesophagectomy with an extended 2-field lymphadenectomy. You have to perform a digestive continuity reestablishment and to promote a high quality in pathological report. Again, ESMO guidelines have well defined the extent of resection. For example, in case of squamous cell carcinoma, the recommended resection is an oesophagectomy with upper partial gastrectomy and a gastric tube interposition. It's the Matune procedure with a reconstruction in the neck. It implies a subtotal oesophagectomy, indicate because you have a multicentricity of squamous cell carcinoma in about 15% of cases. The second resection is for adenocarcinoma, C-word 1 and 2. Again, it's an oesophagectomy with upper partial gastrectomy with gastric tube interposition. Recommended procedure is the Ivor-Lewis procedure, but you can go for Matune if you want to reconstruct in the neck because to avoid intrathoracic leakage. But you can go for a sweep procedure, a left thoracoabdominal approach, if you want to reduce the duration of the surgery in frail patients. For adenocarcinoma, C-word 3 that invade the stomach, or if you have aggressive subhistological subtype, such as poor cohesive adenocarcinoma, the recommended procedure is a total gastrectomy or a oesogastrectomy with a colonic or jejunal interposition. What is the update in surgical approaches? Nowadays, minimally invasive oesophageectomy is seen as the new standard of treatment. There are 3 randomized trials comparing the results of a total minimally invasive oesophageectomy compared to open, hybrid, that means laparoscopic and open thoracotomy compared to open, and RAMI, robotic surgery compared to open. And of interest is the results of these 3 randomized trials demonstrate positive reduction of respiratory complications, in reduction of overall complications, and similar oncological outcome to open surgery. What about the use of minimally invasive surgery in the perspective of neoadjuvant chemoradiation? There is this randomized trial comparing minimally invasive surgery in neoadjuvant chemoradiotherapy group and neoadjuvant chemo, and the results are similar. So what to conclude for surgical approach? Nowadays, minimally invasive oesophageectomy is considered as a standard surgical approach in expert centers, and minimally invasive oesophageectomy seems to be safe after neoadjuvant treatment. What about the indications? For early stage T1 N0 M0, this only represented 21% of our patients. The recommended resection by ESMO guideline is upfront surgery. And you have to consider that for a very early stage cancer, these patients have previously failed endoscopic mucosal resection, and you have to know what are the risk factors of lymph node invasion. ESMO guideline recommend to have a limited invasion for adenocarcinoma, SM2 tumor, and for squamous cell carcinoma, it's a M3 tumor. You must propose surgery when you have in the endoscopic mucosal resection positive lymphovascular invasion, low differentiation grade, ulceration or large tumor size, or when you have positive deep margin, positive lateral margin, or when you have a piecemeal endoscopic mucosal resection. For early stage T2 tumor, we don't know if we have to go for surgery or neoadjuvant treatment. And we have a randomized trial from Christophe Mariette, published in Journal of Clinical Oncology in 2014, comparing surgery alone compared to neoadjuvant chemoradiations, and only for early stage. And this trial show no significant difference on overall survival, and chemoradiations increase postoperative mortality. So the conclusions for T2 tumor is probably neoadjuvant chemoradiations should not be proposed for early stage cancer, stage 1 and 2, and this early stage should be proposed for early for upfront surgery. For locally advanced tumor, T3, T4, or N1, N2, and 3 disease, you must go for neoadjuvant treatment. And in the neoadjuvant treatment, you have 2 possibilities. The first option is to use neoadjuvant chemoradiotherapy. The second option is to use neoadjuvant chemo. First of all, neoadjuvant chemoradiotherapy, what are the data? We have the results of the last meta-analysis showing a clear reduction of all cause of mortality using a neoadjuvant chemoradiotherapy. And this meta-analysis was published before the CROSS trial. According to the histological subtype, squamous cell carcinoma and adenocarcinoma have a great benefit of neoadjuvant chemoradiations. Since this meta-analysis, we have the results of the CROSS trial published in New England Journal of Medicine in 2012, and the results of the CROSS trial increase the role of neoadjuvant chemoradiations. In this trial, the patients received carbotaxol chemotherapy associated with radiotherapy to 41 gray, and the benefits of 5 years overall survival was clear, positive 47% compared to 33%, and of interest is both squamous cell carcinoma and adenocarcinoma have a clear benefits of neoadjuvant chemoradiations. So we can conclude that to date, cross regimen seems to be the gold standard in terms of neoadjuvant chemoradiations for locally advanced tumor. What is the best volume dose of radiotherapy? This is a very good question, and I remind you that in the cross trial, they use 41 gray. And in this retrospective study, it clearly shows that the more you increase the dose, the more you increase the pathological complete response, but at the price of an increased 90-day mortality. So I think the best radiation dose is between 45 gray and 50 gray. This gives equivalent pathological complete response and a similar rate of 90-day mortality. What is very important to understand is the modality of radiotherapy, and nowadays most centers use intensity modulated radiotherapy compared to 3D conformal radiotherapy. What is the future? Probably coming from the proton beam therapy. We have few data on that, and proton beam therapy is known to increase the therapeutic index and probably giving a normal tissue sparing, reducing significantly pulmonary complications, cardiac complications, wound infection, reducing 90-day mortality and probably length of hospital stay. But to date, proton beam therapy is very rare because it's really expensive and very few centers have these technologies. What about neoadjuvant chemo? And I mean neoadjuvant perioperative chemo. Again, we have the results of the meta-analysis from Jokist published in Lancet Oncology, and the meta-analysis show a clear reduction of all cause of mortality at about 13%. But if you look at the histological subtype, squamous cell carcinoma has no effect, perioperative chemo has no effect on squamous cell carcinoma, and the only effect was for adenocarcinoma with a clear benefit of 70% reduction of mortality. So we can conclude that neoadjuvant chemotherapy is only an option for adenocarcinoma only, and squamous cell carcinoma has no benefits in this treatment. What is the best chemotherapy regimen? We have the results of the FLOT trial comparing ECX to FLOT trial only for patients with adenocarcinoma of the gastroesophageal junction and CWERT 2 or 3, T2N plus disease, and there is a clear benefits of FLOT in terms of median overall survival, 15 months compared to ECX, 35 months. So nowadays, we can conclude that perioperative FLOT should be proposed for adenocarcinoma, CWERT 2 or 3, or for poor adhesive adenocarcinoma, such as signet ring cell. The question remain unanswered is, what is the best treatment for adenocarcinoma? Do we have to use between neoadjuvant chemoradiotherapy, or do we have to go for neoadjuvant perioperative chemo? We have two trials who tried to answer this question. The first was published by Stahl in 2009, comparison of neoadjuvant chemo to neoadjuvant radiochemo, and clearly there is a benefits of neoadjuvant chemoradiations in increasing pathological complete response. In downstaging, you have more YPN0 patients. The 3-year overall survival was better, 47% compared to 27%, but at the cost of an increase of postoperative deaths. And very recently, we have this amazing study published by the Trinity College in Dublin. John Reynolds published this abstract at the ASCO meeting. We are waiting for the whole publications. This is a neo-aegis trial, including more 300 patients. Majority were T2, T3, N0, N3, M0 adenocarcinoma of the gastroesophageal junction, and they compare cross-trial to perioperative regimen, including MAGIC or FLOT. And the comparison between the two arms show clearly an increase in R0 negative margin in cross-trial, an increase in pathological complete response, 16% compared to 5%, a decrease in neutropenia, and similar postoperative in-hospital deaths. And in terms of long-term outcome, surprisingly, the two arms show a similar long-term outcome. The 3-year overall survival was 57% for FLOT trial and 56% for cross trial. So what to conclude for adenocarcinoma? I think you can use both FLOT or cross regimen in terms of long-term outcomes. They are giving the same results. But you have to understand that the marker of response after neoadjuvant chemoradiations seems to be better in terms of pathological complete response, in nodal downstaging, in R0 rate, and there are no difference in terms of severity of complication. And I think this question have now to be discussed because we have new data on the role of adjuvant immunotherapy in residual tumor after trimodality treatment. So for adenocarcinoma, I personally believe that neoadjuvant chemoradiation is better and provide a better local control of the tumor. So in neoadjuvant setting, what is the place of immunotherapy? This is unanswered to date, and there is a great rationale because a broad tumor antigen exposure activates the expansion of more diverse tumor-resident T-cell clones before surgery, and probably may intensify systematic surveillance of micrometastases. But what are the results of neoadjuvant immunotherapy? Unfortunately, they are disappointing for squamous cell carcinoma in terms of pathological complete response. Trimodality treatment associated with immunotherapy seems to be favorable, but no after neoadjuvant chemo alone associated with immunotherapy. What about adenocarcinoma? Again, there are disappointing results, and trimodality treatment associated with immunotherapy or chemotherapy associated with immunotherapy are not convincing. So nowadays, we are not able to have strong data to recommend neoadjuvant immunotherapy in esophageal cancer. What about adjuvant chemo? Adjuvant chemo has been well demonstrated after upfront surgery in N+ patients, but what about the use of adjuvant chemo after trimodality treatment? This systematic review and meta-analysis published very recently in Annals of Surgery seems to promote adjuvant therapy after trimodality treatment in terms of decreasing mortality at 1 year and at 5 years. But unfortunately, we have no the detail of pattern of recurrence, and we have no effect on disease-free survival. But I think the most progress we have is probably the role of adjuvant immunotherapy. And we have the result of this large multicentric study, the Checkmate 577, comparing nivolumab to placebo. And in this randomized trial, including more 794 patients, including esophageal and gastroesophageal junction tumor, majority were adenocarcinoma and substantial squamous cell carcinoma. All the patients received neoadjuvant cross trial, and if they expose residual pathological disease, and if they have R0 resection, they were assigned a placebo or anti-PD-L1 checkpoint inhibitor. And the first endpoint was the disease-free survival in the overall populations. And nivolumab significantly increased disease-free survival with a 22 months median survival compared to placebo 11 months. And the adverse event was similar. Grade 3 and 4 adverse events were quite the same between nivolumab and placebo. Of interest is this effect of nivolumab concern not only adenocarcinoma, but also squamous cell carcinoma. So what to conclude? After trimodality treatment, adjuvant nivolumab significantly prolonged disease-free survival among patients with incomplete response after standard therapy for esophageal cancer and gastroesophageal junction. Unfortunately, we have no data after neoadjuvant chemo alone. ESMO guideline has now included nivolumab in this new guideline, and squamous cell carcinoma and adenocarcinoma treated with trimodality treatment. And if the patient has a residual tumor with R0 resection, it should be proposed for nivolumab for at least 1 year. Last part of our discussion is the specific place of salvage surgery after definitive chemoradiations. As you know, squamous cell carcinoma, some patients receive definitive chemoradiations, but sometimes they are proposed for surgery afterward because there are persistence of tumor after definitive chemo. The patients are qualified as non-responders, and they show within 3 months in the same site the tumor after completion of definitive chemoradiations. It could be after recurrence and the tumor is detected more 3 months after completion of definitive chemoradiations, or it could be for a local toxicity when the patient had intractable strictures, ulcer or perforation after definitive chemoradiations. Salvage esophagectomy is a very complex procedure, and literature review indicate that if you have patients with salvage esophagectomy, you have a 3-fold increased risk to increase in-hospital mortality, anastomotic leakage, or pulmonary complications compared to surgery after neoadjuvant chemoradiations. So if you have an indications of salvage esophagectomy, you have to consider 2 risk factors. The first is the hospital volume, and you must perform this kind of surgery in expert centers, and high volume centers reduce significantly the in-hospital mortality, 6% compared to 16%. The second idea is to take consideration about the dose of radiations. And if you go for a salvage esophagectomy after 55 gray, you have a very explosion of all the different outcome markers, such as in-hospital mortality, 27%, in-hospital morbidity, 75%, anastomotic leakage, 27%, surgical site infection, 29%, or pulmonary infection. So the dose of radiation have to be considered, and you must have to select the patient according to the protocol of radiation. Whatever the techniques, if you have to propose salvage esophagectomy, you have to respect few advice in patient selection to balance the indications after radiation's dose up to 55 gray. You must refer the patients in experienced centers to review the radiation treatment plan and to improve preoperative denutrition. The resection should be a subtotal esophagectomy with pericardial fenestration because of high rate of pericardial effusion, and you must avoid completely extending lymph node dissection. You have to very careful dissection of the airway not to injure and create tracheoesophageal fistula, and the place of minimally invasive esophagectomy in this context is not recommended. At last, reconstruction should be a cervical reconstruction because of high rate of fistula in a retrosternal route to avoid contact with the bronchial tree, and you have to consider substantial other substitutes than stomach, and especially colonic or jejunal anteposition if the gastroesophageal junction has been injured by high dose of radiation previously. So take-home messages, ladies and gentlemen. Now, for esophageal cancer, you must adopt standardization of surgical principles in expert centers. Neoadjuvant treatment should be chemoradiation for squamous cell carcinoma. For adenocarcinoma, you can choose between neoadjuvant chemoradiations or perioperative chemo with FLOT regimen. But you have now to consider the possibility after neoadjuvant chemoradiations to propose adjuvant immunotherapy. The radiotherapy should be based on intensity modulated radiotherapy protocol. Neoadjuvant treatment, the dose should be between 40 to 50 gray, and especially for cross-trial 41 gray. And if you go for definitive chemoradiations, you have to limit the dose to 50 gray, not to preclude the possibility of salvage esophagectomy thereafter. And you have to keep in mind that nowadays you have the possibility in trimodality treatment, if you have an incomplete response and an R0 resection, to go for adjuvant immunotherapy. And I think this is the main message, to promote, to go for neoadjuvant chemoradiations and to have adjuvant immunotherapy in this very selected case with a very outcome excellent. Thank you very much for your attention, and I'm very proud to answer your question.
Yeah, thank you very much, Xavier, for this excellent overview. Please feel free to ask any questions via the chat function or the Q&A function, and we can always discuss them. So my first question would be, in the majority of solid tumors, immunotherapy is, from the biological point of view, more effective in a neoadjuvant setting because you have the full tumor in place, and so the effect can be more pronounced. Of course, there are also in lung cancer still some questions open regarding the best regimen, but why do you think the data in esophageal cancer are so disappointing in the neoadjuvant setting?
That's an excellent question. I really don't know. In lung cancer surgery, immunotherapy is well defined and as well demonstrated. You have a very huge pathological complete response. So in neoadjuvant setting, it should be the gold standard in esophageal cancer surgery. But unfortunately, the data are not convincing. Probably a further trial should explain this. The only data and well documented is the adjuvant indications of nivolumab in only adjuvant setting. But I have no scientific explanation why it's not recommended in neoadjuvant setting.
Okay, there is a technical question about lymphadenectomy in the neck. So it's all discussion about 2-field versus 3-field lymphadenectomy.
So in
your routine recommendation?
No. I think it's a good indication when you have a squamous cell carcinoma of the 2 upper third of esophagus to perform a cervical lymphadenectomy. It's a bilateral cervical incision. For adenocarcinoma, personally, I think it's not recommended, even if some Belgian team have clearly demonstrated its benefits. But it's a very huge procedure. The patient has sometimes tracheostomy tube because it's very aggressive. So it's a large debate, these questions, but we don't have enough data to balance between the risk and the benefits. So I should not recommend it to perform bilateral cervical, except if you have a residual N+ disease or very specific squamous cell carcinoma, but not for adenocarcinoma.
So adenocarcinoma is the predominant histology, as you've shown in the beginning. Do you routinely perform cervical anastomosis for adenocarcinomas or intrathoracic anastomosis?
That's again a large discussion. I think if you are confident with your intrathoracic anastomosis and if you have good results with very few complications, I think you can go for IVOLA for adenocarcinoma. But if you experience, like in France or in Netherlands, a very high rate of complications in the thorax, I think you should better go for cervical anastomosis because it's very better to manage cervical leakage compared to the thorax. But the problem with cervical incision is you have more cervical leakage and you have potential left recurral paralysis. So again, you have to balance between the risk of both strategies.
So there's another question about the role of stenting or feeding tube insertion during neoadjuvant chemotherapy in case of tumor obstruction. What's your experience and opinion on that?
I don't really like stenting a tumor, except if it's a palliative situation, but I probably have to discuss with a gastroenterologist. I prefer personally to put a feeding jejunostomy because when you start chemo radiations, in very 15 days, the patient is able to swallow, not very properly, but is able to swallow progressively. And so I think stenting is not really useful, but some publications indicate that stenting do not compromise the neoadjuvant chemoradiations. I think you have to prepare the patients to go for surgery with a good nutritional status and do not hesitate to go for a feeding jejunostomy. What I advise you for, and especially for adenocarcinoma, is to start before neoadjuvant chemoradiations, to go for laparoscopy, to rule out potential carcinomatosis, and to take the opportunity of this laparoscopy to put feeding jejunostomy to prepare the patients for surgery.
What about management in elderly patients? Are there any other algorithms, particularly octogenarians, who might not be suitable for other systemic treatment? What's your approach towards this patient population?
I think we have to be very careful for elderly patients, to be very strict in the selection criteria, because as I demonstrated, the ESG score, it's a prediction of the 90-day mortality. Age after 80 years old is prohibitive. So if you have a patient after 80 years old, I think you can go for surgery, but the patient must have no other competitive risk. I mean, no comorbidities and especially previous infection or vascular disease. It must be a patient 80 years old, but in an excellent condition, fit for operation without any doubt of the risk for surgery. If you have any doubt, I think it's better to go for definitive chemoradiations.
We've discussed in the beginning that esophageal surgery is organized differently. There are some thoracic departments who are doing the majority of the work. In some places, it's sort of split up between thoracic and visceral surgery. So caseload sometimes is an issue. Do you have any threshold or cutoff value where you think this is the absolute minimum number required that should be done annually? Because we know in esophageal cancer this is linked to outcome. And what would be a definition of a high volume center?
There is no clear definition of what a high volume center is. In France, volume allowed by French authorities is only 5 esophagectomy a year, only 5. So it's not a high volume centers. In Europe and in literature review, it's at least 20 a year. In China, it's at least 100 patients a year. So it's very difficult. I think you must be pragmatic. 5 resection a year is not enough to have a good expertise. I think 20, I think I know that in Belgium, they have since the last decade centralization policy, and they increase drastically the results, decreasing the mortality. And I think in Belgium, the few centers and experience at least 20 resection a year. 20, I think it's a reasonable compromise.
So this
what
would
about
be,
you in your country?
This would be your recommendation on a minimum number.
I think so.
Yeah. Also, there's no clear definition of an absolute minimum number, but 20 is also a number I would consider reasonable, and which should be sort of a threshold to reasonably perform the surgery. Are there any minimum numbers for training and for qualification? Because this is another issue during thoracic surgery training. Some minimum numbers are required in a lot of different procedures. I don't think on a European basis we can define a minimum number of esophageal surgery, because many thoracic surgeons are not exposed to it. But for someone to independently practice esophageal surgery, what do you think is a reasonable number of cases that should have been performed under supervision to really be able to start?
It's a difficult question. I think you must be, you have to well manage laparoscopic surgery. This is a basic platform. Numbers of randomized trials clearly demonstrated that laparoscopy is better than laparotomy. This is the first, I think, the first step to understand. If you have no experience in laparoscopic surgery, I think you have to stop the esophageal program, because nowadays laparoscopic surgery is at least the minimum to provide. So at least I think you must have experience out of about 40 to 50 laparoscopy to do properly esophagectomy. But you have to repeat the procedure and to be well trained in laparoscopic surgery. Thoracic surgery is not really a problem. It could be well done by a thoracic approach, open thoracic approach, but you have to focus mainly on laparoscopic surgery. And if you have a good experience between 40 to 50 laparoscopy, I think you can go, you are a master in esophageal surgery. And you are in the standard of minimally invasive esophagectomy. I don't know if I'm clear.
I think this is a very clear statement and sounds reasonable. In some instances, the thoracic surgeons are only contacted if complications occur after esophageal surgery. And of course, management of complications is a crucial issue in any type of surgery. So anastomotic leakage certainly is one of the most common complications after esophageal surgery. What's your standard management approach if this complication occurs in both minor and major problems?
So it depends on the location of the anastomosis. To be simple, if you have a cervical anastomotic leakage, it's easy to do it at the bedside patient. You open the cervical feed and you have the leakage well drained, and there is no other problem. The problem is the intrathoracic anastomosis. You can go for, if you have leakage, you can go back to operating room when it's early fistula, or when you have a complex fistula with tracheobronchial 3, tracheoesophageal fistula. If you have just an isolated fistula or a delayed fistula, you can go with a stenting. But I think, but I have no experience in our centers to use Endovac. I think Endovac is probably the best method, but I have personally no experience because we don't have the technologies in Marseille. And I push all my colleagues to have this technology in the next few months. I hope so. But I think Endovac is the best method because you can clean the mediastinum cavity and you can have a good, I think, what do you say that? Recover of the fistula. So Endovac, I think it's a good technique.
What about other complications? Are there any particular recommendations you can give to avoid common complications after esophageal surgery? Or are there any particular surveillance methods postoperatively in order to early recognize complications if they occur?
So the main complications remain the anastomotic leakage. We have in Marseille adopted for ERAS protocol. The patient is kept nil by months, and we wait for 5 days. We just control the blood samples, the protein C reactive, the C reactive protein. And if it's going down to 150, we can start filling by months. If we have a problem, we go for a CT scan with a barium swallow just to rule out any leakage. And if there are any leakage, it depends on the time. You can go back to the theater, so you can go for endoscopy. For other complications, I mean, it's respiratory complications, and unfortunately, the surgeon has few effect on that. You must well prepare the patient to stop tobacco use, to make a rehabilitation program, to have the patients very fit. And what is very interesting is to prepare the patients for the nutritional status.
Okay, so another interesting topic in many cancer types is oligometastatic disease. Actually, we're also having a webinar on oligometastatic disease in lung cancer in 2 days. It's sponsored by AstraZeneca, and I would all invite you to register for this webinar. But what about oligometastatic disease in esophageal cancer? Are there any data about this or particular treatment recommendations?
We have experience of few cases of oligometastatic disease. There are very few data on that. One of, I think, the best important series come from Leuven University, Leuven de Pieper, who clearly demonstrated that oligometastatic disease is not the end of the road. And you have few cases in very selected patients with a single lung metastasis or single liver metastasis that can be benefits from local treatment. But it's only a case report or short series. I have no very strong data, but I think the most important is the delay between the surgery, the completion of chemoradiation, and the appearance of this oligometastatic disease. The more you have time, the better prognosis is. So for a very metachronous oligometastatic disease, I will very motivated to go for surgery or for a local treatment.
And what about synchronous cases? Do you have any recommendation?
No. In France, synchronous cases, we consider it's a current metastasis.
So you don't operate on them,
no.
You just treat them?
Only patients, they are first treated like a metastatic disease, and after the follow-up, if the patient has no metastatic evolution, and if he has afterwards a very localized tumor, we can go for a salvage esophagectomy in very selected patients, but it's very, very exceptional.
Regarding the time interval between neoadjuvant treatment and surgery, is there any optimal time interval, or do you have any particular recommendations regarding that?
For cross-trial, the optimal treatment is 8 weeks after completion of neoadjuvant chemoradiations to schedule surgery. You can go for 12 weeks after completion of neoadjuvant chemoradiations, but the optimal time is 8 weeks. That's what is normally reported, but you can go for 12 weeks.
And what about if chemotherapy only is given? Any difference?
Chemotherapy only is, I think, quite the same between 6 and 8 months. 8 weeks, sorry. You go for surgery and you have 6 to 8 weeks to go for a completion of perioperative chemo, FLOT, 4 cycles before surgery and 4 cycles thereafter. You have to wait 6 weeks thereafter surgery. But the problem with the FLOT is sometimes the patient is not safe, is not in good status to have the second phase of the perioperative chemo. So sometimes the adhesion of perioperative is not excellent. And I think I remember it, 60% of patients receiving preoperative FLOT receive postoperative FLOT, and 40% do not receive the second phase of perioperative regimen because they are too in bad status after surgery. That's a real limitation of the perioperative chemotherapy protocol.
Okay, here's another technical question about the role of ICG to assess the quality of the gastric conduit vascularization. Do you have any particular opinions on that?
We have experience of ICG. The problem is we can use it very easily in laparoscopic phase, but when you go for a thoracic phase, it's open surgery, but you can also use ICG. I'm not sure that ICG avoid you leakage, but it's make things more easier to localize where I will do the anastomosis. And if you have a doubt on vascularization of the gastric tube, I have 2 or 3 cases, injury of the gastroepiploic artery or injury during dissection. It's very useful. And you can very easily check if you have done a technical mistake. Clearly, ICG is, I think, useful, and you can use it laparoscopically or robotically.
Okay, there is one more comment by Konstantinos Marios Sultanis that they have very good experience on the neoadjuvant FOLFOX regimen. Any comments on that?
Absolutely. Neoadjuvant FOLFOX give good results. Normally, the optimal dose of radiation is not like the cross trial, it's not 41 gray, it's more 45 gray. But today, there is no comparison of cross trial to FOLFOX trial. Probably in the next future, cross regimen will be compared to FOLFOX, but I agree, FOLFOX is a good treatment, and especially for squamous cell carcinoma. But there are no level 1 evidence comparing cross trial and FOLFOX trial.
Okay, so I think we've come to the end of today's webinar regarding the time. I'd really like to thank you very much for giving us an excellent overview on the topic, and also to the audience for the interesting discussion and participation. I'd like to draw your attention also to the next upcoming webinars. The next regular ESTS webinar will take place on November 13th at the same time. And Raman Rami Porter will present on TNM9 classification, what we can expect from the new classification, which is about to come in place at the beginning of next year's. Until then, we have 2 more sponsored webinars, which I would also kindly invite you to participate. As already previously mentioned, shortly this Wednesday, also at 6 p.m., we have the topic of oligometastatic disease, when to operate and novel treatment option. That will feature Alex Pronendi, Isabel Opitz, Nicolas Girard, and Dirk de Roecher. And on October 30th, we have another webinar on key care elements and outcome of postoperative ERAS pathways, which is co-sponsored by Medela. So once again, thanks a lot for participation.
Thank you, Clement.
And yeah, thank you, Javier, and enjoy the rest of your evening, everyone.
Thank you so much. Bye-bye.
Bye-bye.